Okay, I think I am starting to record. I think you have the PowerPoint slide, the first PowerPoint slide visible. And I think you can hear my voice. Um, so thank you, Tara. Your message is received. If you can, please turn on your, okay, isn't it, you see the slide or not? Okay, some can. Okay, thank you for letting me know some can. I'm not sure why. If you can't see it, it's probably on your end. Uh, and if you still can't figure it out, I'm going to upload. So this canvas is back up. Okay, thank you. As soon as canvas is back up, I will upload it. The video as well as the PowerPoint. Okay. Boy, it just seems like forever um, that we had last communicated. And I plus giving you the 2-week time frame to turn in your paper, and I feel a little bit on my end disconnected from you all. Well, I should say disconnected, less connected than I want to be. So I really want to have a sense of from each of you how you're doing. Are you taking this in? Equal is important. Maybe you are taking this in, but you don't think you're taking this in. So I want to assure you that you are. And so that just requires a fair amount of communication. I really, my best source of getting a feel for each of you is in your assignments. So as I read your assignments and we have some idea of how much you've relied on AI or not, and I really say over and over again, try to find that middle ground, but for goodness sake, use it because it's there. But anyways, as you turn in your assignments and I get some sense of what you're getting, what you're not getting. Because everyone will be at a slightly to moderately different pace with this. And what I was, and I'll do this week, particularly if Canvas is down more than 24 hours, I'll have, won't be able to grade your papers. And so I'll have a little bit more time to, and I want to get this done this week. Write up a little bit of an overview of what I think you need to know by the time you finish this course. So you can see your comfort level with some of these things. And there's some things in this course you'll have to know fairly precisely, such as how to go into the DSM, how to maneuver through depressive disorders, bipolar disorders, being able to have some idea of the different disorders within each of these categories. That is, you have to know that. And I think most of you are already there. The challenge for me really, particularly in this course, is it's all online. And I realize there is some gap in getting a sense of each of you individually and collectively. And so I want to, I'll address that at some point. Canvas is back. Okay. I have this morning, one of my dogs, small dogs, has had he's only been using 3 out of his 4 legs for the last couple of weeks. And about a week ago, we took him into the vet. Vet did some x-rays and said, oh boy, I think he's going to probably need surgery. And so this morning, I took the Archie into this advanced veterinarian clinic that mostly just does surgeries. And why am I telling you this story? It's because I went to, when we first checked in, the receptionist said that all the computers are down. We don't know, we can't communicate anything to you. We don't know what your appointment is, what you're coming in for. And then as we began to, just in a few minutes, the computers were able to work, but very, very slowly. So I was talking to my wife about, man, are we dependent on technology? It goes out. We're all going to be cave people again. We're just eating berries and not knowing how to do much else from that. And then right after that, I try to get in Canvas and I can't get on it. And so part of technology is you can't 100% rely on it. And so here we have Canvas. This gives you an idea of emotional regulation, both mine and yours. I can get in Canvas. In one of my classes, I had a quiz today that was due by late this evening, and so that was not great timing either. But it's not anything, no, one darn thing you can do about it, and we just sort of work around it. And what I wanted to accomplish today is different, even though Canvas is up, it's too late now. I wanted to spend a little bit more time going over the assignments, but I need access to Canvas to do that. So I'm going to partially address that. I think it was Tara said she printed off all her assignments. She's a lot more organized than I am. And I'm a slow learner and I have a tendency to learn the thing hard way, but realize now I should have a second copy. And what if my computer's out? It's no guarantee of things, but at least it's a backup plan. Anyways, so for today, and your assignments in the future are going to be tied to this, and so it will get clearer and clearer just by going through some of these slides. What I want to do today first is talk about the diagnostic assessment. It's a pretty big deal. And then we'll get into psychotropic medications. So the thing about learning to diagnose is the first part is just a mechanical part, and getting to know some of the definitions, getting familiar with the different categories, having some idea about the 5 areas of symptoms, being able to look for those things. So that's sort of the first big step, is just that familiarity. We all have to do it. That's where we all start. Some point, though, it's how do you conduct a first session in such a way that you can optimize as much information from the client as possible to allow you to have some visual diagnosis that you can justify at the end of a session. So part of this is, one, being having some knowledge of the DSM. Second is how to apply it when you're meeting with a client. So we've talked already that it's a requirement for third-party insurance to have a diagnosis after the first session. Each organization that you work for is probably going to have a whole different procedure and policy around the intake. So that's the first how that is the expectations on a clinician to conduct a first session, how to document it varies from agency to agency. So what I'm going to do then is talk about what I think are the essentials that need to be in a diagnostic assessment. Talk a little bit about how you are able to achieve that. And then how do you write it? How do you document it? And how do you communicate it to others? And those are all important skill sets. And it could seem overwhelming if you're maybe taking this all in like you need to. It should be overwhelming. It's just, there's just a lot to it. But we all start that way. And what my hope is that I teach this course to optimize your learning both in graduate school and your practicum and your early part of your professional career, to be able to learn at an accelerated rate more than most with some of the preparation that is given to you in these courses. So there's just a lot to it, and let me just get right to this next slide. Take one step back here. I believe that a initial session should be at between 60 and 90 minutes. It might not require that much time, but to try to get all this stuff in a first session, plus on the other, those of you who are taking clinical practice 1, talk about how important the first session is of getting an alliance, getting to hear the patient's story, having them feel heard and listened to and empathize. So, oh my goodness, how do you do both these things in the first session? And we do. when we eventually get there. I will say that a client shouldn't necessarily know he's being diagnosed. 99 times out of 100, they're not coming in there with the investment, I want a diagnosis. They might be curious, and they may have their own diagnosis. They may ask you what you think, something like, I'm crazy, aren't I? Or what diagnosis should I have? But the majority of time, they just have some level of brokenness, pain, trauma, whatever it might be, stress, and they want relief. They want to know, have some sense that this person sitting across from me, this clinical social worker, has some level of competency that maybe they can help me. That's what they come in for. So in them telling their story and trying to diagnose them helps them tell their story. Helps them tell their story as we go. So I'm going to go a little bit back and forth on these slides. Let's start with your organization may require you to take notes or not take notes, or give you the discretion what you want to do. At the VA and other places, particularly bigger organizations, they'll have a pretty structured intake piece. And sometimes that means that you go ahead and enter the communication or what they're telling you into a computer. And if I had a sore throat and other physical symptoms related to that, and they wanted to know my symptoms directly, I get it physically. They want to, and then sort of structure it. And how long have you had this or that? It's a very different, I think, in the mental health sphere. In terms of having this regimented, rigid, structured questionnaire that you have to get through, because that does not allow the patient to tell their story that well. And you're going to be more interested in getting through the assessment, making sure you have all the right information for the assessment, not what's in the best interest of the client. Me, myself, and I've been in private practice many, many years. So in private practice, you get to call your own shots. And I just think those of you who are in clinical work, okay, so let me just see your comment, which is Elizabeth. You want to just verbalize that, Elizabeth? Your
Sorry, it took me a minute to find the mic button. But yeah, my supervisor told me recently that insurance companies don't require you to diagnose in the first session.
Can others hear Elizabeth? Yeah. What the heck is going on? Hold on.
Anyway, that they allow you 3 sessions to make the diagnosis, but you can't bill. So the therapist across the hallway from me, she does that. She takes the full 3 sessions to make diagnosis, but then she goes back and finalizes those notes by including the diagnosis and then bills after the 3rd session. So just a tidbit that I learned recently.
Can you hear me? Is your supervisor in private practice? That's the difference. Yeah, that's, you do have that. You have a little bit more discretion typically with that. There's some risk involved, but that's for another day. And I missed the first 60% of what you said. But I think I got the gist of it. So thank you for sharing that. And by the way, as I go through this in either one of my courses, I invite you to either correct me, update me, clarify things that I'm saying based on your experience, particularly when we get into psychotropic medications. If you have a different understanding than I do on some of the things that I present, please bring that up. And certainly with the assessment piece and anything else that we talk about, because we're all in this together. Although I try to stay on top of things as much as I possibly can, I've been practiced. I haven't seen a patient in 2 years, and I haven't had a full-time practice in 20 years. So again, I try to really close the gap between the ivory tower of university and what really happens. And part of what helps me close the gap are things like Elizabeth, bringing up these things. So I'm spending some time on this because it's something I wish when I was in graduate school, I was told about instead of learning it, learning some of this wisdom over time. One of the things then is I'm a believer. If this was let's say this was a legal pad, I would have the legal pad in front of me, and then I would be taking notes as the client speaks. And I would say, is it okay if I take notes? And I would even say, you can look at them anytime you want. It just sort of helps me to remember. And particularly when it comes down to the first session and assessing, if they say 3 years ago, I started to get depressed. I was depressed once in high school. That was 20 years ago. By the time it comes for me to write all this up, sometimes it's helpful just to have some of those things, and I just do it in shorthand. And there's been a couple times of the hundreds and hundreds of clients that I've seen where they requested I not take notes, or that they could see the notes. And happy to be able to do that. I never want to write anything that can be used against the client. Not in the client's best interest. The exception there is child abuse, other things like that. But short of that, this has to be a safe haven. We don't take information and try to use it against our client, or our profession is compromised. Even the Supreme Court, United States, 1996, gave clinical social workers privilege. It's a legal standing where we don't have to share, just like lawyers don't have to share, information in court unless we get client permission. We have privilege. That said, I've testified in court where I thought I had privilege, judge didn't give me privilege. So, that he didn't give, and so since then I clarify that ahead of time. If I've ever gone to court, and I think I have privilege, communication that might be tested, I communicate with the judge ahead of time. But again, that's for another day. I don't want to get off on this. In the first session, those of you who have taken clinical practice 1 or taking it now, I talk about you want to get their presenting problem. How the client sees their problem, the extent of it, how serious it is, relevant information about that problem, how long it, same thing applies here. You want them to tell their story. When you're doing the diagnosis, though, you're gonna be a little bit, you'll clarify a little bit more on symptoms. When did it start? How severe is it? How has it impaired your functioning? And that helps a client tell their story. And it also conveys to the client, because most people in casual conversations who talk about their problems to others, the other people don't. One thing they typically don't do is try to clarify the severity, frequency, and intensity of symptoms. And when you try to clarify that, that shows to the client, that demonstrates in many cases, ooh, this person really cares, really concerned. Don't want to put diagnosing a patient as the most important thing in the session. The most important thing in the session is connecting with their client. But once you have a little experience, and maybe some of you are pretty close to that level of experience, that some of those skills cross over. Those of you who have mostly been in case management have the most struggle. Because how you assess a case management, how you communicate, how you document, it's going to be very different than in a clinical setting. Very different than when you're diagnosing. So, presenting problem. You want to get the client's presenting problem, and you want to pay attention to the symptoms that they might bring up. So remember the 5 categories of symptoms: affect, emotion, and thoughts, behaviors in a person. You want to be able to, if you miss some of those things, it's fine, but get try to capture the most important pieces of that. When did this start happening? It's some sense of pre-morbid history. Pre-morbid meaning what their life was like before these problems started to occur. Pre-morbid history. Patients who have had chronic, very complicated lives, and many who come for clinical work will have that. It's hard to even tell any pre-morbid history, right? From the time they were small children, their lives have been dysfunctional. So pre-morbid is more helpful when there has been some prior to the symptom, some level of normalcy, I'll just say that, in their lives. So I'm going to just stop here. Just at this point, just a thumbs up or thumbs down, or any other questions you have at this point. Thumbs up, Elizabeth. Okay, thank you. Yep, okay. Yeah, thank you, thank you, thank you. Um, so let me start with this, demographics. That is gonna tell an important story. You need demographics. When I on a clinical supervision part, we don't teach it anymore, but I'm really pushing to bring it back. When you present a case in clinical supervision, and I've been clinical supervisor for many years, um, before a case is presented, I want to know how old this person is. Female, male, who's living in the house, getting some sense of demographics. Employment. So, demographics should be filled out in the waiting room on a application and not something you do in a session. You tell me how old you are. That is not getting off on the right step. And we're used to filling out just simple things. Name, age, occupation, uh, education level, socioeconomic is very important, very important. Live in a house, other things like that. And I take that into me, in with me in the first session so I can reference it. So I see you've been married here 3 years and you're currently separated in the last 4 months. Is that right? So far, so good with demographics. It's very important. And if we were in the classroom, it's just hard for me to figure out how to do it here. But when you're in the classroom, I would ask just to brainstorm what are important demographics. If you're this program will have very little focus on children, diagnosing children and clinically treating them. None of us have that expertise, and I know some of you are interested in working with children. Most graduate schools don't do child therapy justice anyways. And you'll need additional supervision and training anyways to work with children. That said, when you're doing an intake with a child, depending on the age, you might be seeing parent or parents first. And then the child, or maybe not the child, or so we document that differently. Let's just assume who you're seeing, an adult or teenager coming in individually. Then writing the presenting complaint or presenting problem. And this will be one of your assignments, is to be able to draft, how do you capture in the least amount of words a pretty good rendition of the essential pieces of the patient's presenting problems. So if you think about the movie Beautiful Mind, and if you imagine if you had John Nash come in to you when he was a graduate student, doctoral student, you might get a very different picture than if he came in 10 years later, 15 years later, when he's sordidly psychotic most of the time. By the way, it'd be very difficult to have any kind of intake assessment. My guess is that in the beginning of the movies or how he presented himself, he'd be very resistant to go in and meet somebody. And if he did, he wouldn't be very talkative. But anyways, capturing the client's presenting problem. I say in here, use client's words sparingly. Try not to quote the client. I think it's okay to do that, but what I found in these, as I teach this, students overquote. So only use a quote and only use a quote when the client says something that's particularly compelling or particularly revealing, and have it be just a sentence or half a sentence or something. Like, I ain't got no problem. That's pretty definitive. And you talk to him and it's not, doesn't think he has a problem or whatever, I might put that in there. That's what you call. Otherwise, or beyond that, then it's important for you to describe in that first session, to summarize how this person sees the problem. And next is clinical impression. And this is probably the highest level skill in all of this. Even more difficult than conducting the session itself is being able how to document it. So the clinical impression, it tries to convey what's it like from your perspective? What's your impression of what you're seeing with this client? Everything from, and here on the slide, assessing appearance, their sense of mood. So mood congruence. The mood congruence is feeling. One example would be he's talking about the recent death of his mother, and he seems to have no emotion about it at all, or he seems to be angry about it, but try to let someone who's reading what you're documenting have some idea of what you're seeing. Important not to repeat what's already been said in the presenting complaint. So if the client says he's been depressed for 5 years, hasn't worked for 2 years, that goes in the presenting complaint. That's his story. No need to put client has been depressed for 5 years in the clinical impression. The clinical impression is how you see this client coming across. Assessing appearance, mood, behavior, speech, thought in the session. So it could say that client seemed to be here to be very sincere, motivated, help, and my sense is that he or she conveyed things in the most honest way he could. And that's a little bit too subjective, but looking for things like that. The level of patient insight, how aware are they of their problem or not? a lot of times patients will come in and it'll be everybody else's problem, not theirs. If my boss would just treat me this way, if my wife would just treat me that way, my children, it's important to get some sense and in your clinical impression, as it appears that client takes very little responsibility for his own issues and contributes them. I'm gonna close the door, they're vacuuming. Somehow want to be able to note that. I have in here egosyntonic, egodystonic. Know what that means. It's such a useful term. And it'll apply both to clinical practice and diagnosis. And basically, in a nutshell, egosyntonic is whatever problem the client might see, they have very little motivation in changing. They're not troubled by it. Egodystonic is some of these things that they're experiencing, they desperately want to change, desperately want to look at, or take some steps in the right direction. So play with those terms. And for purpose of this course, I just would ask for you to have the basic rote definition of it. But over time, the more you try to look for egosyntonic, egodystonic, as people tell their stories, very helpful. You want to get some idea of, well, functional impairment, relevant history, things like that. Clinical impression. The idea of orient times 3, orientation times 4. Nurses do that a lot sometimes in you're expected to do the mental health. Orientation, you know where you are, you know what date it is, you know your name, basically a little bit of a mental status kind of thing, orientation type. Typically only do that if you think the client is psychotic in some way or not grasping reality, get some sense that you even know who you are. But you don't want to ask that to every client. Particularly if they seem reasonable and it's unnecessary. Same is with suicidality. I would ask every client in the first session, have you thought about hurting yourself? It may be so far from anything they're dealing with, and you have no sense that that's even an issue. I wouldn't ask it. I would not ask it. On the other hand, if you have the slightest suspicion, then it's important. So demographics, presenting complaints, clinical impression, and then the last thing, and this will be on the assignments, and we'll practice with it, is being able to justify your diagnosis, your provisional diagnosis. What did you see in this session? Let's assume you have to make the diagnosis in the first session. What are you picking up on that lead you to believe the client's depressed, bipolar, or anxiety disorder, of course, to give some sort of justification? The remaining assignments will largely be around being able to look at some cases and being able to pull from those cases what you might be picking up on, and then come to an idea of what your best guess of diagnosis. And I'll just use the word guess loosely here. And so how I'd like to set it up, and we'll have to wait till the following week, is first do it in small groups, just a consensus. And then move to being able to do it on your own. Because some of you might understand this to some degree, but not completely clear. And what you do understand, someone else might not be completely clear. So I'm going to divide you up and just give you a case and come up with this simple, probably half a page to 3/4 of a page diagnostic assessment. Let me get to the next slide. Okay, so we're going to be getting into psychotropic medications after this. So we are, and psychotropic medication is going to be on your licensing exam. You're going to have to know some basic things, the ethics of it. We are part of the privilege of being able to diagnose. I mentioned this first week of class, is we have been licensed to practice medicine in that sense. And we have a responsibility as a clinical social worker to know some things about medications. So that's going to be in a few minutes. But because this is largely interprofessional, we're working with physicians, nurses, psychologists. The professional we are in communicating to this interdisciplinary team, the more respect you'll get. And people will, this is less and less now. I've seen the change over the years for the better, but physicians in the past, psychologists to some extent, were dismissive of social workers. And maybe they had good reasons, I don't know. But if you want to represent your client well, and your perceptions, at least we want them heard. And part of it is being able to communicate. If you work in a hospital, you're going to be doing a lot of it. If you work in private practice, maybe it's a quick phone call or something in documentation form. So professional writing, third person, not first person. You don't want to say, I saw the client do this and that. Nor do you want to say, this social worker saw the client do this and that. It is, client appeared to do this or that. So that's third person. Get comfortable with that. And when I first required to write in the third person, I thought, oh my God, I should have paid attention to fifth grade English. where they went over this. What is the difference between first person and third person? And then just slowly, it's the enculturation process of the profession. Slowly it becomes easier and easier. So third person, use the least amount of word for the most information. That's a sort of adage of mine. The more you write, the less likely someone's going to read it or find what they're looking for. And the more you write, and this is where case management is different. Case management, you want to cover everything. You start covering everything, your documents get subpoenaed. And you have to justify every statement you wrote. You don't want to be all over the map. So the idea of writing as efficiently as possible, that's where terminology comes in. So I'm going to give you more terminology today. And one of the things that's going to be on the list of what you need to know before finishing this course is going to be, it's going to be in green, yellow, and red. Red is going to be those terms you absolutely have to know. They're not a lot, 8 to 10, maybe 12. Yellow are pretty important words, begin to play with it. And green is words you may or may not come to, but it's not going to be an emphasis in this class. So I want you to put your energy into the reds. I'll go through these bullet points. I don't want to spend too much time on them, but they're also important. At an agency, organization, field practicum, you want to know how the assessment process works and what you're required to do before you see a first client. You want to see a client, and then what I'm supposed to do with it will help you focus on what you need to pay attention to and how to write it up. I talk about use non-definitive verbs, talk more about that, but things like appears, alleges, states, reports, expresses. Instead of saying client is not an alcoholic, certain of it, say that client alleges he doesn't have a drinking problem, denies any drinking. Then, if later on he's a full-blown, very serious drinking problem, go back and say, there was no evidence of it. I asked him about it. I moved on from it because it was in your notes. That was the justification. Vary your pronouns. And the bottom line here is frequency, intensity, duration. That's really going to be helpful in terms of these symptoms. When did it happen? How often does it happen? How intense are they? And how long do they last? And you can get to some of that just in a couple of minutes. I think we're in the first section. Thumbs up. Any questions? Thank you. And if it's a thumbs down, then please either set up a time we can meet online or send me an email. I'm pretty darn good. This was sort of my commitment this semester. Not going more than 48 hours responding to an email or a message, and I'm about 95 percentile. So I know it's important, but to learn about your assignment, what I need for the assignment, but I love questions that have to do with the material. Please feel free, right, or sit. Okay, now I'm going to shift. There's a lot of slides here, some of which, and we're gonna wrap up at 8. So I'm gonna get through all of them, but they're all gonna be there, and this will be helpful for you when you study for the licensing. Because I try to, and as the best I can tell, this is up to date as of this year of my understanding of psychotropic drugs, what's out there, side effects, all those kind of things. So all of it, but I'm going to talk to you about what you need to know as a clinician, licensed practitioner. Right off the bat, you cannot prescribe a medication. You can't tell a patient to take this or don't take this unless it's prescribed or it's PRN. If you have concerns about patient's medication, one, if you can trust the patient enough to tell their doctor, saying, in your notes, I'm concerned about this, I emphasized patient needed to communicate with doctor, and you have that trust, you've covered yourself. Or oftentimes you call the doctor yourself. But, so the things that we're responsible for, one of them is not messing with medications they've been prescribed to take the amount, unless it's an emergency of some sort, and then call the doctor. Okay. So it's important for you to know side effects in general, what to look for. So all these medications, particularly the antipsychotic medications, are heavy duty. And sometimes the clients can assimilate these medications fairly well, and sometimes it's difficult. You saw in the movie. It's almost better. Do I want to feel like I've been hit by a hammer and I have no sex drive, I can't think straight, I'm tired all the time, I walk stiffly? Do I want that? Or do I just want to take my chances and be crazy? Maybe the sanest question is, I want out of these medications. So know the side effects. Also in a position to educate and advocate for the client. Help educate them on the medications to a limited degree. How the field is right now is psychiatrists have 2-3 month waiting lists. Then finally see a psychiatrist, and maybe it's a 90-minute, does a great job. And then the psychiatrist doesn't see you for another month or so for a med check in the beginning, depending. Maybe they rely on us to monitor. So to be able to help clients understand their medications and advocate for them. So the big piece is collaboration with the prescriber. If you're in practice, doctors have friends who are family physicians and are desperate almost to have practitioners, they can refer clients to work with and trust and build relationship and all that. So part of it is collaboration, and I'll get into the ethics of it as well. Okay. I don't have time to show you this, but it is, I was looking at both actual patients being assessed in initial assessment and some that might be acted out. Acted. This one on mania was perfect. If you've never seen someone actively manic, this is what they look like. There's others. There was one, they did a demonstration on a person who had active psychosis, schizophrenia. And it, to me, I could tell it's acting. And so I chose not to use it. But I want to find some that are good, and I'll post them for you to look at. So anyways, this is just a 10-minute session trying to deal with someone who's manic and trying to get through this darn session. Because every question you ask that person, they'll take it in this direction or that direction. And it's exhausting. And you're feeling, oh my God, I got to get all this out of him. What will my supervisor think? And ain't going to happen. Not going to get it. In many cases. So get a chance to look at that, and I'll put some more on. Okay. These are the general categories. Psychotropic medications are medications specific to mental health. And in medical lingo, they talk about it as antipsychotics, antidepressants, anti-anxiety. It's just, these are the realms, as well as mood stabilizers. So to have some idea of this. So clinical social workers work more with people with schizophrenia than any other profession. And so if you're working with people who have serious mental illness, it is your ethical professional responsibility to know, be familiar with the first and second generation medications. Not so much the dosage amount. It doesn't hurt to know what the range of dosages, but that's beyond it. But to know what they're taking and the side effects. The psychiatrist is often depending on us to pick up things. And if they don't see a patient for 2 weeks, 4 weeks, the patient misses, or there are these side effects can progress and become adverse. And some, with particularly antipsychotics, should be permanent. So knowing what medications your patient is on and keeping track of that, what's maintaining, what's working, what's not working. So in this column here where it says PRN, PID, that's going to be in the green area. You could look at it, maybe just know if that's what PID means or whatever. These are all Latin derivatives. But what's more important is in the left, this column here. Know what, this will be red. Indications, contraindications. It's largely in medicine, but it's also in treatment planning. And let's mostly with medication. Indication is whatever the group of symptoms this client has, this type of medication or family medication is indicated. It's a medical term, indicated. Contraindicated is the type of issue, problem, symptoms the client has. This medication is typically indicated, but for this client, it's contraindicated. Example is, let's say, with anti-anxieties medication, which is pretty addictive. And you have a client that has an addictive issue with substance or alcohol, and alcohol potentiates. That he can go into a doctor and just convey the part about needing something for his anxiety. You know this client, have some sense that is contraindicated for him or her. It's important to communicate that in some way. The physician, how you communicate, some doctors or PAs are clear. This is what they expect. All of them, they want to talk to you. Some don't have the time to talk to you. You leave a message with administrative assistant, or you write something briefly up. You just have to feel your way through that. You don't want to alienate anybody. And we're partners on that. And then the more pressing the issue that you need to talk to somebody, the more you just need to make sure and get a hold of somebody on their side. But indications, contraindications. Have some sense of side effects, the main side effects, particularly with antipsychotic medications. So to know some levels of side effects. And then part of our responsibility working with clients is to get some sense of, are they compliant or non-compliant with taking their medication? That doesn't mean we have to absolutely follow up every day of the week to make sure they're taking the medication. It does mean is that we check in with them from time to time. And either it comes up, they bring it up, or you check if they're compliant or not compliant. So potentiation, titration, efficacy, tolerance, know these things. This will be in the red category. Let me go back. Potentiation, efficacy, tolerance, dependence, withdrawal. Know those. I think maybe tolerance and dependency and withdrawal will probably be in the red. Something you have to know. Okay. But not so much potentiation and those things. So our key responsibilities is one, having some awareness and how compliant or not a client is. And being able to, at what level you want to monitor them. So there might be some high functioning patients on antidepressants. You just bring it up from time to time, if at all. And they pretty good about letting their, but with more severe the case, the less likely of any kind of consistent compliance, then it's important for us to get on top of it and communicate. Real quick on on psychotropics. They work with neurotransmitters. That's what they do. And although psychotropic medications work with more neurotransmitters than just these listed, these are the big ones. And it's made it into the vernacular of our day about dopamine and serotonin. People throw that word around casually. That's a neurotransmitter. Or the medication works directly and only affects a certain neurotransmitter that it's supposed to affect, the less side effects. Antidepressants, for instance, fairly simple and often just are serotonin uptake inhibitors. Just work with serotonin. Antipsychotic medication will do the same, including working with dopamine and some of these others. But it also hits other neurotransmitters that aren't the reason for the problem or something, but just it's where we are in the pharmaceutical advancement that it still affects other types of neurotransmitters. And that's where the side effects come to a large degree. So we just know that antipsychotic is almost like a shotgun. It hits a lot of the right stuff and some of the wrong stuff. While serotonin or antidepressants, a lot of times just primarily it's the right stuff. So basically, neurotransmitters go through this synaptic gap, the axon and dendrite, okay, and axon and dendrite, of which there's 100 million of these things in somebody's brain at the minimum. That the dendrite is responsible, let's say, for sending the neurotransmitter serotonin to the axon. So the dendrite sends these little chemical molecules. What an uptake inhibitor means is when somebody has depression, the dendrite produces the serotonin, but it never makes it to the axon. It goes back into the dendrite at the synaptic gap. That's why it's called an SSRI. The uptake inhibitor, instead of this going back into the dendrite, it inhibits it to go to the axon. That's as much chemistry as you'll need to know. And so here I laid out not only the technical names, but the commercial names of a lot of these medications. I've been on and off of Prozac for my last 30, 40 years. My guess is most of us have been. For me, it's absolutely no side effects. And I take it for irritability, not depression, irritability. I read somewhere a long time ago that could be helpful. Not that I'm a particularly irritable person, um, but when I get stressed and all that, and I'm raising my small children and a single dad, um, I get more irritable than I wanted to, and boy, that just made a difference. So I'm sure some of you are on it. There used to be shame with it, and hopefully that goes away. And it's just a great medication for some people. Um, to know that it takes a couple weeks, 1 to 2 weeks, to get some sort of benefit. So you work with a client about that. There might be a lot of side effects in the first 2 or 3 days, and so the client wants to stop. I'm tired, I think straight, I'm nauseous. What I found though, most of my practice is just anecdotal, is the more of those kind of mild symptom or mild side effects, the more likely the drug is taking effect. So part of our goal is just hang in there. I know it's rough now, but let's see what happens in the next couple of days. Okay, so this is really the first line of, in many cases, with antidepressants. But then there's antidepressants that work with both serotonin and norepinephrine. Then there's tricyclic antidepressants, sometimes referred to as atypical. And I just want to talk about this for a minute. This and MAO inhibitors here, phenothiazine is not an MAO inhibitor. Okay, I'll have to fix that. Anyways, both those have a little bit more effect with the elderly in smaller doses, or if people are depressed really and the SSRI is not working, you can go on this and it works better. But there's a lot of, you can't drink alcohol, mix alcohol with this. You can't mix alcohol with certain cheeses, other things. So not easiest. That's why in nursing homes, or it's a little bit easier to prescribe these, you can monitor it better. So these are the varying list. You don't have to remember for my class, this course, anything really other than the SSRIs. I just want you to know there's categories up there, categories, so some familiarity with this. Okay, so anti-anxiety usually is benzodiazepines. And they're pretty darn effective. Oh my goodness. They're not meant to be prescribed more than 3 to 4 months because they're addictive. You can habituate, so you need more and more of it. And a lot of times I work with clients to just have that Xanax or Ativan in their pocket or in their purse to know they can have it is enough. And they really get anxious if it's not there. So that's part of the management of it. And so as I say here, there's a dependence on it. It's potentiation with alcohol. So one mixed drink might turn into 3 mixed drinks potential wise when you're taking that. And so use caution with substance use history. That's where we come in, communicate. Mood stabilizers. Lithium, discovered in 1950. Let me just very quick aside. Remarkable, really. They found there was a place in Australia, small town, or a mid-sized town. This is in the 50s, that had a disproportionately low amount of people that had bipolar disorder. They called it manic depression back then. And it was so interesting. Someone checked the water. There's high lithium content. Boom. That's next thing we know, we have lithium to this day still being used for this. It's sometimes used for bipolar, often. And this is where psychiatrists come in. So I'm a big believer that the general practitioner can do antidepressants just fine. And if it's just straight depression and not complicated, that maybe they don't really wait line for psychiatrists and all that. Once you get into high anxiety or psychosis, well, that's where psychiatrists come in. And they can mix all sorts of things with some, so when this 1980s, early 90s, it was almost taboo to mix any antidepressant with a bipolar person. And now I see it all the time. So that's not my area. But the one thing about mood stabilizers is that you have to monitor, you have to have a therapeutic blood level. So take a little bit of time to get, so it titrates. Maybe you need a little bit more, a little bit less, whatever that might be. An occasional taking up blood level. When you're bipolar and the mania feels so darn wonderful, it is tempting to say, I think I'm okay. I've been stable for a while, and stop taking the medication. So it takes a fair amount of relationship with the patient, staying on top of it, education, all those kind of things. Mood stabilizers. So first generation antipsychotic medications are, which are sometimes referred to as typical, that's why I put it on there. Came out in the 1950s, came out, and like so many, Prozac was on the cover of Time magazine twice in the 1980s, almost as a cure-all. Someone said, let's put it in the water and drink it because everyone will be happy. There's always, this is my professional experience over the decades, with medications or a new type of treatment, people are jumping on board saying this is the best and greatest, and either fall flat or come somewhere in the middle where it's helpful, but it's not to the degree that everybody had hoped. Then you have pharmaceutical companies promoting this stuff, which is $1 trillion agency. And so it gets all mixed up, but antipsychotic, the typical, came in the 1950s. They thought we don't need institutions anymore for mentally ill, and hence the deinstitutionalization, 1950s, saying we'll just do community mental health, so release everybody because we have these medications and it helps some, but not everybody, and on and on. That said, and you saw it play out in the movie, it's awfully effective, particularly for the positive side effects. There is no reliable medication for the negative side effect, negative symptoms of schizophrenia. That is a red area. You must know positive and negative symptoms of schizophrenia. It's vital. And like you saw in the movie, boy, it's tough to take. It affects how you walk in physical motion. you look like you're medicated. The last thing someone with schizophrenia needs to do is stand out in the general public and bring attention to themselves. The key, though, is the extrapyramidal symptom that is called tardive dyskinesia. That will be on your license exam. Tardive dyskinesia. I told you about the neurotransmitters. Well, these antipsychotics will affect same transmitters that's affected by Parkinson's disease. So we begin to have very similar symptoms as Parkinson's. If you catch it early enough and you withdraw the patient from that or substitute something else, goes away. It is possible, and it happens, that they have it, the symptoms long enough, becomes permanent, can't be reversed. If you want to look at why clinical social workers get malpractice, this is one of the areas. They should have known it, they should have seen it, not just once but for months on end. Didn't know to look for it, didn't know to say anything about it, or whatever they might be. You're going to be put in the mix. Okay, so anyways, you work with people with schizophrenia, be familiar with that. Second generation came in the 1990s. Again, it was promoted as almost the cure for schizophrenia. I was working with a patient who was one of the first ones on a trial for this. And it turned out that his physiology, they did blood tests and found that he's at high risk for it, so they took him off of it. But to this day, you're gonna, it's a little bit better, less side effects, more effective often than typical, but you still need to go in for blood work, and some, and this is where psychiatrists can do cocktails, and and then you take medication for the side effects of some of these things, and for some people it makes a difference. Medications typically from antidepressants on will help somebody 10% to 70%. There's no medication that you take it, your work is done. Antidepressants, you take it, which allow you to do your work. So medications don't teach you anything. Psychotherapy does. Lastly, ECT, you saw that in the movie. It is a little bit more humane these days. There is, it's for, and this is another word you're going to have to know, refractory depression. Refractory anything is hard to treat, medication resistant. So someone who is very, very depressed and tried this antidepressant and that antidepressant and this and that, and nothing touches it. And it is getting into the quality of their life in significant ways. This is to be considered. I had a close friend that went through this. This was 15 years ago, so hopefully they've advanced upon that. But she had to go to Austin once a week, Austin, Texas, to get this treatment. And then her and her husband wound up just living there for 2 or 3 months so she can get her treatment once a week. Disrupted her life. Her memory was impaired, didn't come back. Not a great experience, but that's just one person that I'm familiar with. I just tried to read a little bit of literature on in preparation for today. And there is some efficacy meaning effectiveness of treatment with this. And we're getting better and better at being able to, just the terror of being in a electric shock back in the 60s, 50s versus now, very, very different. But it takes a lot of processes along the way, talking to the right people and being evaluated and educated and all that, but it's out there. And if we had more time, we're in the classroom. I want to know if anybody knows of anyone who has this experience or knows of psychiatrists. You need special licensure for this or training. But this is what I want to leave you with is anything I said in here that you have a different understanding or you can improve upon or you can correct, please let me know, particularly here. Well, anytime, I should say. But I just want to make sure that I give you the most accurate information possible in this realm. For you to have some sense of your responsibility. That's why we had clinical supervision. And that's why we had clinical supervision for 2 years. Is the person supervising you chooses to supervise you and you're working with this kind of population, that person should have a fair amount of experience with it that they can pass on to you. So we're at 8:02. And once again, what I'll do is I'll upload this the next day or two, but I'll stick around. Anybody have any questions? Otherwise, I will see you guys one last time. I think this is our 3rd. Yeah, one last time in November. Okay, take care. Thank you.